Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Good morning and a warm welcome to our distinguished panelists and all those who have joined this edition of the Hindus Wellness Series presented along with Naruvi Hospitals. The theme of today's seminar is liver transplant, and I am your host, Shoma Basu. As we understand, the liver is the largest organ, solid organ in our body that performs over 500 vital life-sustaining functions such as helping in food digestion, storing energy, removing toxins from blood, and much more. Like every other organ, we have to take care of our liver for healthy living. But when due to various reasons, when the liver starts struggling, it sends out distress signals. We feel tired, nauseous, our skin looks pale. So instead of ignoring the symptoms, we should go to our specialist doctors for the right assessment of the extent of damage to the liver, because the liver can also work and regenerate if only part of it is damaged. But if liver failure occurs, it cannot be controlled by medical treatment. Only a liver transplant is a solution. To discuss every important aspect about liver transplant and clear all myths and doubts surrounding it, we have a distinguished panel with us today. I would like to request all our attendees of this session to listen to the three reputed doctors with patience and post once the question and answer box is open for you. You may also direct your questions to the specific panelists if you wish to, and I would be happy to squeeze in as many questions in the given time. It is my privilege to introduce a very senior gastroenterologist like Professor Ashok Chako, with more than 4 decades of experience in the field. Currently, Dr. Chako is serving as the head of the Department of Gastroenterology and Liver Diseases at Naruvi Hospitals in Vellore. He retired as gastroenterology head from CMC Hospital, Vellore. A graduate of Stanley Medical College and MD from Christian Medical College, Dr. Chako has held the post of National President and TN Chapter President in Indian Society of Gastroenterology and also been the President of Indian Medical Association, Vellore Chapter. Widely traveled and recipient of multiple awards, Dr. Chako is also a fellow of the Royal College of Physicians, Glasgow. He has served on special advisory boards of the Medical Council of India and the National Board of Examinations, establishing a state-of-the-art endoscopy unit at CMC Vellore. He has published close to 100 papers and also peer-reviewed research studies. And I think all these have been the hallmarks of his fulfilling career. A very warm welcome to you, Dr. Chako. Dr. Chako's colleague, Dr. Sanjay Gobel, is the lead liver transplant surgeon at Naruvi Hospital, Vellore, and also Apollo Hospitals, Bengaluru. Dr. Gobel was the former professor of surgery at CMC Vellore, where in 2004, he performed Tamil Nadu's first successful live donor liver transplant. With 20 years of experience in liver surgery and liver transplantation, Dr. Gobel, I'm sure, will have lots to share with our audience today. He completed both his MBBS and MS in general surgery from CMC Vellore and followed it up with an FRCS. He has won multiple awards during his academic career and has nearly 75 papers published to his credit. A very warm welcome to you, Dr. Sanjay Gobel.
Thank you.
The youngest member on the panel, but no less accomplished, is Dr. Sandeep Satsangi, with an MBBS and MD in internal medicine from KMC Mangalore and a DM in hepatology from PGI Chandigarh. He's now working as the lead consultant hepatologist and liver transplant physician with the Apollo Comprehensive Liver Care Team at Bannerghatta Apollo Hospitals, Bengaluru. The university topper and the best outgoing student trained himself extensively in liver diseases. He has several publications in various international and national journals and has also authored chapters in several books. Under the program ECHO that involves telemedicine services, Dr. Sandeep has been involved in training community level physicians in Punjab in the field of hepatology. Welcome, Dr. Sandeep.
Thank you.
So, audience, I will now hand over the floor to Dr. Chako, who will give a presentation on liver transplantation, followed by 2 more presentations by the other panelists. So over to you, Dr. Chako, now.
Thank you, ma'am. A warm good morning to all our viewers. I'll be speaking on an overview of liver transplant. As Ms. Shoma has said, the liver is an important organ. It is situated in the right upper part of the abdomen, and it is reddish brown in color and weighs about 3 pounds. There are two main lobes, the right lobe and the left lobe, the right being bigger than the left. It is an organ which has got more than 500 vital functions. So with so many functions, it is understandable that when the liver fails, life also fails. Some of the important functions are processing of your food and drugs. The liver produces bile, which helps in absorption of fat and fat-soluble vitamins. Liver makes proteins that helps in blood clotting, and it helps in preventing infection by regulating immune response and removing bacteria and toxins from the blood. So what are the diseases, common diseases that cause liver failure leading to a liver transplant? Broadly, it can be grouped into 3 groups. One is the chronic liver diseases, that is liver disease going on for a period of time, which leads to complications and liver failure. The second group is acute liver failure due to drugs like a paracetamol overdose or anti-TB drugs in some people, or toxins like rat killer poisoning. And of course, liver cancer is another important cause for a liver transplant. Among the chronic diseases, the common ones are alcoholic liver disease due to excessive alcohol consumption, a non-alcoholic fatty liver disease where the fat builds up in the liver, causing liver damage. I'm sure that many of our viewers would have had an ultrasound abdomen taken with a report of fatty liver. It's quite a common finding on ultrasound. But what we should note is that 20% of them, 1 in 5, will over a period of 20 years develop liver failure leading on to a transplant. Of course, infection with virus hepatitis B and C is another important cause for a liver transplant. So once liver failure develops, which is not controlled by medical treatment, the only recourse to save life is a liver transplant. Unlike the kidneys, where you have dialysis to prolong life, we do not have such an option for liver transplant. So what is a liver transplant procedure? A liver transplant is a surgical procedure where the diseased, no longer functioning liver is removed from the patient and replaced with a healthy liver, either from a diseased donor, that is a brain dead donor, which is called diseased donor liver transplant, or from a healthy liver from a living donor. A portion of the healthy liver is taken and transplanted to the patient, and that's called a living donor liver transplant. A brief note on the history. It was Dr. Thomas Tarzel who performed the first liver transplant, human liver transplant, in 1963, at the University of Colorado, USA. Unfortunately, that baby died due to bleeding on the table. After a few more unsuccessful attempts, Dr. Tarzel performed the first successful liver transplant in 1967. Many of those early cases died because of rejection of the transplanted liver. The rejection happened because of formation of antibodies in the recipient patient. So it is Dr. Roy Khan from the Naruvi Hospital at Cambridge, UK, who introduced this drug called cyclosporin in 1979, which improved immunosuppression and helped in transplant success. Recently, many more immunosuppressants are in place and which help in decreasing rejection. Incidentally, Dr. Roy Khan was the first. He did the first liver transplant in Europe. What about India? The first diseased donor liver transplant was done in 1995 by Dr. Leena Girinath at the Apollo Hospital, Chennai.
Dr. Chaku, if I may intervene, your slides, I think, are not running. Is it so,
Surgeon operative.
Dr. Gobel? Do you
Yeah,
see the
sir,
slides?
you have to put it on to the full screen mode. You've got it on the.
I've got it on a full screen mode.
No, from your PowerPoint. Your PowerPoint has to be full screen. You haven't got it on full screen. Anyway, sir, it's all right. You're nearly
You
done.
can continue, no problem.
Yes,
Please
continue.
continue. Please continue.
It doesn't matter. Your presentation, your speaking is very clear.
Yeah, okay, sir.
The first successful deceased donor liver transplant, as well as the first successful living donor liver transplant, were performed by Dr. Rajshekhar in 1998 at the Apollo Hospital, Chennai. In the last 20 years, there has been significant increases both in the technology of doing transplant as well as in the number of transplants being done. Presently, about 1,000 to 1,500 liver transplants are done annually in India. It is done from around 40 centers in the country, most of them in the private sector, and about 85% of the liver transplants are living donor liver transplants. But what you should remember is that there are still about 30,000 patients on the waiting list waiting for a liver transplant. And while they are waiting, many of them die due to complications. This can be saved. They can be saved if there are more people who donate their organs after death. So there is an urgent need now for more organ donations, which can lead to more liver transplant and saving of lives. So I would request many of our listeners to pledge to donate your organs after death. It's quite easy. You just need to fill in an online donor form and send it to NATO, which is the National Organ and Tissue Transplant Organization. And they will send you a donor card with a government registration number. You should also remember that organ donation can happen only after death. And anybody who pledges to donate organ has also the option to withdraw the pledge at any time. I'd like to end with a case history of one of our patients. This is Mr. J, who was 55 years old, was diagnosed to have chronic liver disease 4 years ago. At that time, his disease was easily controlled with medical treatment. However, for the past 1 year, things have not been good for him. He's been having severe abdominal distension with fluid, which required removing about 4 to 5 liters on 3 occasions. His kidney function showed deterioration. He had lapses of memory and mental confusion, which we call hepatic encephalopathy. And in view of the deteriorating condition, he was advised a liver transplant. We will now journey with Mr. J and try to understand the elements of liver transplantation, the pre-transplant processes, the surgery itself, and the post-transplant care. These will be dealt with by the next 2 speakers. Thank you.
Thank you, Dr. Chako. I would like to now call Dr. Sanjay Gobel to give his presentation.
It will be Sandeep, ma'am. Sandeep is talking about next.
Oh, first Sandeep. Okay, Dr.
First
Sandeep.
Sandeep.
Dr. Sandeep Satsagi now.
Yeah, Soma, is my screen visible?
Yeah, it is. It is.
Thanks. Yeah.
Thank you.
So thanks, Dr. Chako. Thanks,
Sandeep,
Soma. Thanks.
Sandeep,
Yeah.
same thing. Go on to full screen, boss.
Okay, 1 second.
At the bottom, near where
Yeah,
it says-
I've done it full screen, sir. I think there is.
Okay, it's still not coming on this.
Oh, is it? Oh,
Yeah,
I think the same issue with.
Yeah, it's coming. It's coming now. Because
It's coming?
slide.
now it's moving. Yeah,
Is it moving now?
Yes, we got the next slide now.
we've
Yeah.
got the next slide.
One second. I think I'll just do it this way. I think it's better.
Yeah, okay.
Yeah. So thanks for organizing a very good event today on a very pertinent topic. So today, my basic aim over the next maybe 7 to 8 minutes is very briefly talk about the symptomatology and what you need to look at when you're thinking about a liver disease and planning for a liver transplant. So what is liver transplant? It is basically, in very simple terms, replacing the dysfunctional liver with a normally functioning liver. This can be done by a living donor related route or by a cadaveric donor related route. And by the cadaveric, I mean is person who's having brain death and whose organs are safe to be donated. In liver transplantation, what is the most important reason we do it? When the liver is not functioning, that is liver failure. It can be acute or it can be chronic. Now, what do I mean by acute? Acute is something wherein today, for example, my liver is working completely fine, but something suddenly hits my liver, and the most common thing is going to be virus infection in the liver, and the liver suddenly starts to fail. And medical treatment doesn't seem to work, in which case the patient goes into acute liver failure without having any pre-existing underlying liver disease, and that requires liver transplantation. And what do I mean by chronic liver disease? Chronic liver disease is often termed as cirrhosis of liver, wherein the liver is scarred and the functioning of the liver slowly over the years starts to go down. And these patients also require a liver transplant. And then the development of liver cancer is again an indication for liver transplant. So very basic in this, I just wanted to show one slide which shows the burden of liver diseases. And you can see that this paper was basically from India, a very recent paper showing that the burden of liver disease is actually constantly increasing. Let it be because of alcohol, let it be because of fatty liver, or because of hepatitis B, the burden of liver disease is actually slowly increasing in liver disease. So by liver cirrhosis, in very simple layman language, what we mean is that the liver, which is a very soft organ, slowly becomes more hard and structurally becomes distorted. So it's not able to perform its function. So you can see that this is a normal liver and the one on the right is a cirrhotic liver. So in the box, you can see a lot of common causes which cause liver cirrhosis, that is chronic liver disease. But in India, the most common cause is going to be one, hepatitis B, and second is going to be lifestyle disorders. In lifestyle disorders, we include people who consume excessive amounts of alcohol or people who have fatty liver, as Dr. Ashok pointed out. Yeah, so in this, I think, because this is completely related to animation, I just wanted to show you one slide wherein how much is significant. This is a very important point, how much of alcohol is significant. So 20 grams per day, both for males and females, is defined as significant. Now, what is 20 grams per day? You can see over here that 30 ml of whiskey, 100 ml of wine, or 240 ml of beer is akin to 10 grams of alcohol. So here I'm not suggesting that please you can take this amount because this is safe. But what is described is that if you have no other risk factors, usually consuming anything less than 20 grams is considered safe. But the problem in India is most of the patients look like this. That is, they have a paunch and they have other risk factors wherein fatty liver is also happening. And these patients are also consuming some amounts of alcohol. So it's a dual impact on the liver and a dual damage which happens in the liver. That is the reason it is best to stay away from alcohol, have a good active lifestyle, and control your obesity, diabetes, and hypertension. What are the common symptoms? The most important thing we need to understand is most often the symptoms of liver disease are very non-specific. You are not going to have a lot of symptoms in the initial stages. You are just going to have some abdominal bloating sensation. You're going to have some excess constipation, some gas. And most of the times, people don't visit their doctor for these symptoms. That's the reason a very high index of suspicion should be there. Whenever you have any of the risk factors, for example, you're suffering with hepatitis B, for example, you have obesity and you have uncontrolled diabetes, you always have to take these tiny non-specific symptoms very seriously and get yourself evaluated. But in an advanced condition, what are the symptoms we see? Jaundice. Here you can typically see that when you have excessive yellowing of your eyes, the white part of your eyes, or excessive yellowing of your urine, often associated with itching over the skin. This is termed as jaundice. And this is called as ascites. Now, what do we mean by ascites? That in your belly, a lot of fluid is going to accumulate. It is going to make the belly very tense. People are not able to eat properly. Their appetite drastically goes down. And they notice that their weight is increasing. But actually, when they see their muscles are actually shrinking, the muscles in the body are actually shrinking. I'll show you a photo of that. The patients are going to notice that their legs are typically getting swollen. And if you actually press it, it actually has a very pitting nature. So this is called as pitting pedal edema. It's often a very early sign of failing liver. And this is intestinal bleeding. This is a photo of a foot pipe, of your foot pipe on an endoscopic image. And you can see how an internal bleeding will occur. And that will present as a massive blood vomiting or passing of black, tarry black stools. These are symptoms seen in the advanced stages. And not only the liver, but also it affects other organs. And the most common organ is going to be kidney and the brain. In brain, what happens is the ammonia chemical goes up and people start getting affected in terms of subtle changes in personality and in far stages to complete coma. And again, a very typical sign wherein you're seeing that the muscles, a person's muscles are going to get wasted, but still his weight is increasing. But that weight is increasing is not because of muscle or fat, it is increasing because of fluid retention. So very important point. Again, I think a few common misconceptions which I just wanted to point out. So liver failure does not affect other organs. It's a very big misconception. Liver failure absolutely affects all the other organs in its progression. The most common organs, as I discussed, is going to be brain, kidney, eventually also affecting heart and lungs. Liver transplantation should only be done in very advanced stages. Again, a very big no. Again, the most important prognostic marker, the survival after a transplant, is directly connected to how sick the person is at the time of transplant. So liver transplant should not be done very early or very late. So how do you know that? That is based on certain scoring. I don't want to go in great detail, but just remember people who have liver diseases, especially cirrhosis, should be aware of one score called as MELD score, sodium score. So MELD score is a very simple score we can calculate. And if the MELD score is more than 15, it indicates that your liver functions are pretty bad and you need a transplant. And you can see over here, which I wanted to show one basic photo. This is our form in which we exhaustively look at other organs, that, whether the liver failure is already affected other organs or not. Because if other organs are affected in a way severe way, many of the times transplant is not feasible. So that's a very important point. Only people who consume alcohol suffer from liver diseases. It's a very common question which I get in the OPD that, sir, I never have consumed alcohol. How come my liver is having cirrhosis? So no, slowly this lifestyle disease in terms of fatty liver is becoming the leading cause of liver disease in India. And another misconception that, sir, I don't want a transplant because people don't survive after transplant. It's a completely false statement. That is because you can see that the survival in India actually is really improving. I wanted to show you one nice figure. Yeah. So this you can see is a data from the US, Iran, and India. And you can see at 1 year, the survival reported from India is as much as 92%. And at 10 years, more than 80% people are going to survive after a liver transplant. So this is a very important point. I just wanted to share a couple of stories with you. So this was one patient which presented to us around more than 4 years back. Very bad liver failure. The daughter stepped up and actually donated a part of her liver. And this was just 2 weeks after the transplant and ready to go home and doing very, very well. This patient over here, again, a very, very sick cirrhotic patient having very bad jaundice, was in liver coma. And the daughter actually donated. This you can see again, just 3 weeks after transplant, completely normal life without any issues. This was one of the most sick patients which we actually transplanted, completely having, because of liver failure, this patient had kidney failure, was in complete liver coma on a ventilator, having lung involvement as well. And the wife came up to the occasion and actually gave up the part of the liver. And this was 4 weeks after liver transplantation. So this is how the success stories of liver transplant actually pan out. So to conclude, initial symptoms of liver disease are very non-specific. In case you have any of the risk factors like hepatitis B or fatty liver, or you consume significant amount of alcohol, it's imperative that you screen for liver disease and ensure that you are picked up in an early stage of liver disease. And liver transplantation provides complete cure, especially if it is in an advanced stage. And the timing of liver transplantation is very crucial. Do not delay it till the very end, wherein other organs are getting affected. Thank you.
Thank you, Dr. Sandeep, for that very fascinating presentation. I would now request Dr. Sanjay Gobel to give his presentation.
Thank you. All right, my screen is visible.
Yeah, it is.
Yeah. Okay, so I'm just going to give you, thank you everyone. I'm going to give you a presentation on liver transplantation before, during, and after. Now, this is the kind of patient that both Dr. Ashok Chako and Dr. Sandeep have sort of painted the picture of prior to transplantation. This is roughly what they look like: big belly, especially chronic liver disease, jaundice, big belly, hard nodular liver, very wasted muscles in the arms and legs. And this has all been adequately covered before, so I'm not going to go into any more detail. Suffice to say that what we're trying to do with the timely liver transplant is move away from this path of the old life, which has a dead end. Most patients who require liver transplant have an anticipated life expectancy, which is if we're talking about acute liver failure, we're talking in terms of days. And if it's chronic liver disease, we're talking in terms of maybe months or a year and a half. And trying to shift you onto a new life where one can, as Dr. Sandeep has shown with some of the pictures, restore you to being able to do everything that you were able to do prior to the onset of your liver disease. So as has been explained, liver transplantation, except there are special types of liver transplant which do not involve this, but the most commonly performed variety is where the entire diseased liver, the entire liver is removed and the liver is replaced with a healthy liver from a donor. Most often, this is a diseased donor because clearly you cannot take out a complete liver from anyone else except somebody who has already passed away. This is what is replaced within the body. And so this deceased donor transplant involves a brain dead donor, that is somebody who has had a very severe brain injury, as a result of which they have lost the capacity to breathe on their own, to maintain their own blood pressure. And usually within about 24 to 48 hours, the cardiac function will also deteriorate and stop. And it is in this interim that these brain dead patients could be donors if their families agree to have their organs donated. So the surgery involves, the liver is supplied by a large vein from the intestine, which carries, which is called the portal vein. It has an artery from the aorta, which is called the hepatic artery, and the blood flows out of it through these three large hepatic veins into the vena cava back to the heart. Also, there is the bile ducts, which are draining bile out of the liver into the intestine. So the transplant operation involves dividing all these blood vessels, these three blood vessels, as well as the bile duct, and removing the liver from its attachments. This is often a bloody operation because, as Dr. Sandeep stated, the liver becomes now scarred and contracted, and the normal blood, which would normally flow out under low pressure through the liver back towards the heart, is unable to do so. And just like a traffic jam, the blood backs up inside this portal vein and is under very high pressure, so that even a little bit of bleeding, which we normally encounter under normal types of surgery, can become quite severe because of the high pressure of blood within the abdomen. But this is what we're used to dealing with, and we have enough, if the need arises, we obviously have blood replacement. And also, since the liver produces all the clotting factors in the body, and a diseased liver is unable to provide these clotting factors, patients can bleed excessively, and these clotting factors have also to be replaced during surgery. The transplant process just involves putting in the new liver after taking out the old and reconnecting all these blood vessels, and as well as the bile duct. Now, this is obviously, as I mentioned, a diseased donor or cadaveric liver transplant, because we're taking the whole liver from a person who is dead. Now, the amazing thing about the liver is that it has this tremendous capacity to regenerate. Now, this is a picture of Prometheus, who's the son of Zeus, one of the Titans, and he brought fire down to earth from the gods, and was punished by his father by being chained to a mountainside on Mount Olympus, and an eagle would come during the daytime and eat up all his liver. And during the night, it would regenerate and the eagle would be back the next day. So this was to be the rest of his life. And, sad for Prometheus, but great for the rest of us that the liver regenerates and regenerates so quickly. And we take advantage of this fact by doing two additional types of transplant. One is what we call split liver transplant. So if we have a cadaveric donor, instead of putting the whole liver into just one patient and treating just one potential patient with liver failure, we can split that. We can remove the liver, or within the donor, we can split the liver into two and give the right lobe to an adult and the left lateral segment to a smaller segment to a child. And the liver that is in the adult will grow to the full size that the adult requires, and the liver that's in the child will grow to the size that the child requires. So you can actually help two patients from one donor. And and additionally, this has gone on to the development of living donor liver transplantation, where obviously you don't want to remove the entire liver. We most commonly remove, in an adult, we remove the right lobe from the donor, and we replace the patient's liver with the right lobe from their donor. And what is left over in the donor grows back, and what is given to the recipient grows to its full size. Now, who can be a donor? They are ideally should be related, although the government does allow unrelated transplant in very selected instances. The blood group must be compatible. There is no need for any other fancy testing to check compatibility. 18 to 50 years, the donor should be 18 to 50 years. They should be fit and healthy with no obvious liver disease. However, you can never do an operation, however well-meaning you might be, which has absolutely no risk. And the risk to the donor is in the region of 3 to 5 per 1,000. This is from all across the world. The donor usually requires 7 days of hospital admission on average. Usually it's somewhere around 5 to 7 days. And we advise them to be off work for about a month before they get back to all their normal activities. And they go back completely to normal. We have donors who are fishermen. We have donors doing hang gliding off mountains, and they're completely normal. The patient after the surgery spends about 3 days in the ICU and 2 weeks in hospital. The risk to life related to the operation within the first few months, first month or so after the operation is roughly about 5%. And there are a number of restrictions which the patient requires to follow for about 3 months after the operation. Now, increasingly nowadays, this is the standard incision which is on living donors. It's quite a big incision, and although the donor gets back to normal life, this is a permanent reminder of what they have, the tremendous courageous act they have performed. But increasingly now people are shifting over to doing minimally invasive donor surgery so that they are not left with such a big scar, or at least that the scar can be hidden. This scar is where the liver is removed from, and these scars are from where the actual operation is performed. So this is increasingly available in our country. With regards to the post-operative recovery, as I mentioned, they spend approximately 2 weeks in hospital. The early the complications which contribute to sometimes to mortality, the most significance is the what is called hepatic artery thrombosis. I showed you the hepatic artery coming off from the aorta. It's a very small blood vessel, and in approximately 1% of patients following the operation, in the first few days after the operation, it can get blocked. And in order to identify this early and deal with it, we do regular scans both during the operation and after surgery to look for this complication. It can be fixed in about 50 to 60% of patients, but if it's not identified quickly enough or it's not treatable by medical means, then this can lead to either retransplantation or death. The bile duct is also narrow. Remember, this occurs in about 1% of patients. Bile duct narrowing is not a life-threatening complication, but it can be a nuisance and may require endoscopic stenting and sometimes surgery. Most patients are very worried about rejection, but as Dr. Ashok Chako mentioned, there are excellent drugs for rejection nowadays, and it's rarely, if ever, a life-threatening complication. It's something which can be easily dealt with. Infection, since we're suppressing the patient's immunity with immunosuppressive drugs like cyclosporin to prevent the rejection, patients are at risk of developing infections. During the early period following the operation, these are normal infections which are from bacteria which are within their own body, which in a normal post-operative patient would be of no significant consequence at any rate. But here, because the immunity is suppressed, some patients can have difficulty fighting these infections, and they can sometimes be severe and rarely lead to death as well. However, fortunately, so one has to achieve a balance between giving the right amount of immunosuppression so that you don't push the patient into, you don't want to give too much. If you give too much, then the patient will be immunosuppressed and get an infection. And if you give too little, then the patient may develop a rejection. So you have to achieve that balance. And people like Dr. Sandeep are, excellent at all these kind of, taking care of the patient regarding this. Sorry. Finally, I'd like to end with this last slide, just going quickly through a few of the important things for a patient after transplantation. First of all, remember that patients who've undergone a transplant require to be on immunosuppression for the rest of their life. This is often a very low dose. It's a high, you're on a lot of immunosuppression for the first 3 months, but after that, the amount of immunosuppression drops drastically. And by around a year, you're usually on 1 tablet or 2 tablets in a day, not unlike somebody who's got diabetes or high blood pressure. You need to maintain the basic level of hygiene. You don't have to go crazy sterilizing everything and you eat and everything around you. You have to be careful particularly in the first 3 months while you're on a higher dose of immunosuppression. But at the end of that time, you can gradually get back to your normal activities. But you need to continue, basic hygiene like making sure you're drinking clean water, not eating too much stuff on the roadside, and where you might get infected and so on. Your diet, you need to be careful. In fact, many patients after liver transplant put on too much weight. And if you look long term, actually, it's not liver failure which they get into trouble with. After transplantation, it's usually obesity and cardiac diseases and things like that, lifestyle diseases, because they tend to put on a little too much weight. So your diet needs to be healthy, but it also needs to be controlled, and one needs to exercise regularly so as not to gain too much weight. The whole purpose of liver transplant is for you to return to your normal work. And again, we have patients who are from being farmers to being executives, to being, as I mentioned, fishermen, all kinds of really physical kind of work as well as desk work you can get back to. You have to take any potential infections seriously, and you need to obviously inform your doctor, whichever doctor you might be seeing, that you're on immunosuppressants. And that you've had a transplant, so that the drugs that they prescribe are not toxic to your liver, to your new liver. Women can get pregnant, from approximately a year after they've undergone the transplant. They can become pregnant and have a family. Men also retain their fertility, but medical supervision is necessary, particularly in the early period after the transplant. And as time goes on, the need for medical supervision becomes less and less, although it never completely goes away. And probably, once in 6 months or so, it's still necessary to have a checkup. As Sandeep mentioned, patients feel that you don't survive after a liver transplant. But here is a group of, a long-term follow-up of patients with transplant. And you can see that children, 72% of them are still alive at, more than 25 years or, nearly 30 years after a transplant. And for adults, of course, the number is much less. This is not because they do badly. It's just that most adults are somewhere in the region of around 50 to 60 years old at the time that they undergo the transplant. So frankly, if they live till they're 75, 80 years old, that's pretty good, especially when we know that most of these patients would not have survived a year without the transplant. So when done appropriately, and when, liver transplant is a life-saving surgery for patients with end-stage liver disease. The timing has to be chosen, but the purpose of transplantation is for you to get back to a normal life. And this is possible in the vast majority, probably somewhere around 80 to 90% of patients will be able to get back to a completely normal life. In fact, sometimes we are unable to recognize our own patients when they come back a year later, because they look completely normal and so different from when they underwent a transplant. Thank you very much.
Thank you, Dr. Sanjay Gobel, for those very interesting inputs. I have just one very basic clarification to seek. Like
Sure.
Dr. Sandeep also mentioned in his slide presentation that basically you have to look out, for the symptoms. So as a doctor, how much, at what stage do you decide that, so much percentage of liver has been damaged and it cannot be cured or treated with medicine. So now you have to go for the patient requires a liver transplant. So what is that extent of damage to the liver till which one can wait and then go for liver transplant?
So it's very difficult to actually quantify exactly what percent of the liver is diseased. But if you look at a patient who has cirrhosis, for example, they have a very long period, which can sometimes be, 15 years, 14, 15 years, where they may not even know that they've got cirrhosis most of the time. Because God has given us a lot more liver than we need. And remember that the liver also regenerates. So whenever there is an injury, it regenerates. And so you can keep going for a very long time. But a point will come when you will start developing some of these symptoms that Dr. Ashok Chakor and Dr. Sandeep spoke about, where the liver is now no longer able to perform its functions for your normal daily living. So this may be that, at that point you either develop fluid in your belly, or you develop jaundice or swelling in your legs, and so on. And once you reach that sort of stage, your life expectancy is limited. Now, that maybe you may still carry on. It's very variable, but on an average, depending on what symptom you have, you probably have 1.5 to 2 years on average left. Obviously, some will be less than that, and some will be more. But that's the point at which you need to start seriously considering liver transplant because transplant is not the kind of activity where, it's not like a hernia where you say, oh, I've got a hernia or a gallbladder and I'll go tomorrow and have my operation. This is a big event. It requires the entire family to participate. And therefore, a certain period of planning is necessary, both from the patient's part, evaluation from the doctor's part, and there is a legal process also which we have to go through to ensure that the right thing is being done for the patient. So all this takes some time, and if you're going on a cadaveric waiting list, then your wait may be 6 months, it may be a year. So there's no point waiting until you're so ill that you don't have any time left to be on the waiting list. And these are the benefits actually of a living donor, where you don't have to go on a waiting list and you can immediately get you can get the operation done fairly quickly. On average, I would say roughly around 60 to 70% of the liver is diseased by the time you develop these symptoms.
Right. Dr. Chako, how would you advise our listeners, like how do they choose a transplant center? I don't know how much information is available outside. Like, is it only done in the private sector, or we also liver transplants are done in the government hospitals? Then the cost factor comes in. So we could first a little bit elaborate on how does a person go about identifying a transplant center?
See, as soon as Sanjay said, when the doctor tells you that you must think of a transplant, I think you need a transplant because you're coming more often to the hospital. You need more number of admissions. Then it's a disturbing fact for the patient, because suddenly they don't know where to go, they don't know what to do, they don't know how much it costs, and they're scared. When you say transplant, they're always scared. Where do I get this organ from? So then they are directed by usually the treating doctor saying, okay, you need to go. You can either have it done at our hospital, or you can go to another place, you decide. So some of the features or criteria one should look at when you choose a center is find out how many transplants they have done. What are the types of transplants they've been doing? So you know something of the experience of the surgeons as well as the rest of the team. The second, do they have adequate infrastructure? Do they have specialty teams? Because this is a teamwork. It is not just one person who can do the whole thing. You need a transplant surgeon, you need a transplant hepatologist who will look after the patient before and after. You need an anesthetist who is giving anesthesia for transplant patients. You need a good ICU with a good critical care person there to look after postoperatively. You need good radiology with an interventional radiologist. You need a good endoscopist, like bile duct injuries may have to be treated either by an interventional radiologist or an endoscopist. So you need a big team, as well as these patients, as said earlier, may develop a kidney failure, they may be having a cardiac problem, they may be having a neurological problem. So you need to have supports in all these areas. So it must be an area or a hospital which can deal with all these. That is the second. Third, they must find out what is the success of transplants in that area. Are they having at least close to the success rate that was mentioned, at least 70%, 75% survival at 5 years, and a 90% plus survival in 1 year. So the survival must also be good. And finally, the cost, which is very important in our country. The average cost of a transplant is around 25 to 30 lakhs in most private hospitals. Some hospitals may charge a little less, but generally this is the rate. So some people, they will have to know the cost, because whether they can afford it or not. Most often insurance is not paying for it, and if they're doing life related, then the cost is more, because there is a cost for the patient and there is a cost for the donor. This donor also goes through surgery and there's a surgical cost. They must also know what is the cost post-surgery, because you need to have immunosuppression, medicines, you need to come regularly to the hospital to do investigations, and there is an extra cost after transplant with that. So all those information should be gathered, and then they should choose where they would like to go to, depending on the expertise available as well as their pockets. Regarding In fact, about 95 plus transplants, percent plus transplants are done in the private sector. The first hospital that started, a public hospital or the government hospital that started cadaveric transplant was the Stanley Medical College and Hospital in Chennai. But after the person who started it has gone, the numbers have come down. So there are not many, there are central government hospitals in the north which are doing, but most state government hospitals, it is not really available. And there the cost is definitely low. It was about 2/3 of what is charged, or less than 2/3 of what is charged in the private hospitals. So cost is definitely a factor. So these are the various criteria you need to look at when you choose.
Yeah, right. Because 25 lakhs is an exorbitant amount. So where does the poor man go then? How does he get treated for a liver failure?
The sad thing is that this is not a poor man's disease. I'm sorry to state it this way, but it's a fact. The fact is that unless you can actually see, you may be able to get together 25 lakhs from, like, many times we have many of our patients who cannot afford a transplant. And even at Apollo, there are many social media agencies, and there are a lot of people, philanthropists, including the chief ministers, politicians and various people who are willing to put together the money that is necessary for the surgery. So you can, and many doctors are willing to do it for deserving patients, would be willing to sort of try and subsidize as much as possible. The problem is actually whether the patient can then take care of themselves after the transplant. They need to be able to continue their immunosuppression, which in the first 3 months may cost them around 30,000 odd per month. But by about a year, you're looking at less than 4,000 or 5,000 a month. But the point is that if you're somebody who cannot afford that, I think it's probably not a good thing to go ahead with the transplant, because you'll have the transplant and then things will go very badly wrong if you're not able to take care of yourself and that liver. The good thing in Tamil Nadu is that, and some other states, governments are increasingly getting involved in helping some patients get immunosuppression post-operatively on certain schemes. Now, this is not universally available, but it is, one of the ways. So that's what if you can't afford a transplant, then you need to get crowdfunding. You need to go to various places to get funds. You need to be able to make sure that you can take care of yourself and the liver later. The fact is that if you're a man with chronic liver disease, you're not going to get crowdfunding because everybody assumes you're alcoholic.
Oh.
But if you're a child, if you're a woman with a, say a genetic disease or something like that, which has caused it, and even some men, if you're able to get the story across that it's not any fault of yours that this happened, you are able to generate funds. We have a lot of good people in this country of ours who are willing to help.
So is there any difference between, like, when you take a cadaveric organ or you take it live? Is there any difference in quality of surgery and life expectancy later? And also, is there any difference in the cost? Dr. Sandeep, would you like to take that?
Sure. So I think it's a very interesting question. Usually in our team, we are actually more pro living donor transplant. I'll tell you the basic reason for that. So in one of my presentations, in this recent presentation, I actually pointed out that, the prognosis depends upon the stage of the patient is in for the liver transplant. But in a cadaveric program, what happens is there's a long waiting queue. So you need to wait for a very long period of time. In that time, what happens is many people deteriorate. So many people actually become quite sick. Their other organs are affected. So many of the times what happens is they're not medically fit to undergo a transplant once the cadaveric organ becomes available. So the most important prognostic marker is at the time of transplant, how are you? So in living donor transplant, the advantage is that we can time the transplant. We want to do it next week, we can do it next week. We want to postpone it by a couple of weeks, we can do that. So that is the biggest advantage of a living donor transplant. Otherwise, in terms of success, in terms of long-term outcomes, I would say both are equally good, especially in a center which has very good capable surgeons like what we have. So we have absolutely seen no difference in terms of survival, but technically, yes, living donor transplant surgery is a little more technically challenging, but with experienced hands, it's completely same. So I think the message which should go is that both are equally good, but if we have a living donor at hand, that's better, because what happens is you don't have to wait in a long queue to get a cadaveric organ. In terms of cost, actually, surprisingly, what we have seen is that living donor transplant is a little less than a cadaveric transplant. And the reason is because of this reason that we can plan the transplant. So, you actually optimize your patient and then you take up for a transplant. So living donor transplant usually comes up to a 2 to 3 lakhs cheaper than a cadaveric transplant.
And what is the average waiting period?
So it depends upon the blood group. So usually what happens is the commonest blood group being O, and the commonest in the recipients also, if we see that in O positive, that's the maximum waiting list which is available. So usually in our center, the waiting list for O positive is going to be approximately between 6 to 8 months. In A and B, it is approximately around 3 to 5 months, and AB is very fluctuant because AB is a very rare blood group. So you have a very less waiting list. You can get the organ just in next week, or you have to wait for a year as well. So that's how it is.
So Dr. Chaku, when you mentioned about how to select a transplant center, so is that all those information, that reliable information, is it available on any common portal or website where a person can go and search? Dr. Chaku?
It is available, yes. It is. All the informations may not be available, but some information is available online from me, because each transplant center do put up their success rates, general costs. But usually what I advise my patients are, go to the place, talk to the physician or the surgeon or both, and then get all the information you want to get from that place. And usually there are large volume centers. As I said, there are only few large volume centers. And the large volume centers are probably what patients see, how many they do, what is their success rate. They are more expensive, but they are large volume. And those who have money problems usually will go to a smaller volume center where the cost will be less, as well as most of them now, transplant has become quite common, and the results are reasonably good in most of the centers. So this is available. Ideally, it's best to go to each center and find out themselves.
Dr. Gobel, I think you mentioned about this age, 18 years to 50 years
For a donor.
Right?
Yeah.
So is there any kind of gender barrier or age barrier, like a woman donor can give to a male recipient, or vice versa, or a young person can give to old can give to young? Is there?
Yeah, there's no problem. You can across ages and genders, as long as the donor is fit. I mean, the most important thing in a living donor operation is to make absolutely certain that there is no harm done to the donor. I mean, obviously you want the recipient to do well, but it should never be at the expense of the donor. The donor is already doing enough, and you need to make sure that the donor is going to be able to go back with absolutely no long-term disability or consequences of having donated, and they should feel good about having donated. So, but there's no gender or age thing. So we have parents giving to children, husbands. I mean, unfortunately, the fact of the matter is that it's more women donating to, wives donating to husbands. That's the nature of our society, I guess. But there's no problem. We have had brothers to sisters and husbands to wives as well.
Yeah, the two examples also Dr. Sandeep showed was daughter to father.
Yeah, exactly.
Right.
Yeah.
I think pandemic times and sorry, you were saying something.
Just in addition to the last question you asked me, the list of centers in each state is up there online, at the Noto website. So all the centers in the country doing transplants or who got a license to do a transplant are available.
Right. Oh, that's useful. Okay. Now pandemic times and everybody is stressed out. So Siva Vignesh GP wants to know, somebody who's COVID positive, somebody who was COVID positive a month ago, can he take a hepatitis B vaccine? And if so, after how much gap? Dr. Sandeep?
So yeah, so there's absolutely no doubt he can go ahead and take the hepatitis B vaccine once you are recovering, you have recovered from the COVID infection. So 1 month is a good enough time. They can go to their routine protocol of 0, 1, and 6 months. So 0 is the 1 day today, and 1 month from today, and 6 months from today. The 3 course can be started, no problem at all.
Okay. Dr. Sanjay, Kandaswamy Ramanathan wants to know, in the PET scan of a 71-year-old female.
I saw that, ma'am,
Huh.
but I don't think there's enough information there for us to be able to answer.
Okay.
And I wouldn't like to give an opinion on something as important as this without
An additional input also. The patient has some syndrome.
Sjogren's. Yeah, I don't know. Sandeep, Sjogren's syndrome, hypodense lesion in segment 3. I don't know whether, you know.
So I think, yeah, too little of an information. I think there's no connection with Sjogren as such, but Sjogren can cause something called as an autoimmune hepatitis, which can cause some liver scarring. And if that is there and there's an hypodense lesion over there, we need to evaluate. And first thing what we need to rule out is obviously a tumorous lesion, whether it is a liver cancer or something coming from outside, which we call as liver metastasis. But I think we need more information. We would want to look at the images. There's something called as tumor markers, which are needed. So I think that should not be taken lightly. And I think he can see his local gastroenterologist or a hepatologist and a liver surgeon in the local place to take it forward from there.
Right. So now if a liver transplant fails in a person, can a second one be done within a time frame?
So there are two kinds of failures. If you're looking at an acute failure, for example, you get a hepatic artery thrombosis as a complication, you're in that unfortunate tiny minority, and the liver is irreversibly damaged and requires retransplant. Theoretically, yes. In practice, it's much less frequent than one would want it to be. Abroad, because there is a lot of cadaveric donation, if you need a retransplant, you can get you will get a priority, and you can do it in a day or two. You'll get an organ. In India, it's a lot more difficult for a number of reasons. One is that organ donation is not frequent enough. Although you will be given the highest priority to get a retransplant, it's often the frequency of donation is not enough that it may not be timely for that particular individual. Secondly, costs. I mean, if you're looking at one transplant is bad enough, having two is horrible. And the outcomes of a retransplant are likely not to be as good as the first time round, because the patient will now be in a compromised state from the liver, having undergone one surgery which has failed, possibly will have infections and other things. So it may not be possible. But yes, in an appropriately, a patient who absolutely needs it, if the patient is considered fit enough to undergo the surgery, the family is willing for all these difficulties, it has been done. And once again, very often when this is necessary, patients are given a lot of financial help during that difficult time. But it is still going to be a major undertaking. If you can sometimes get a liver failure and the need for a retransplant because of some other reason. There are certain diseases which after many years can come back in the new liver, or if you've not been, you sometimes a small minority of patients have a type of rejection which cannot be managed medically. Then those patients would require again a retransplant. In that case, there is usually time. And a sufficient time has usually passed from the initial transplant so that patients may be able to consider it even financially. And at that time, if it's necessary, again, it can be done.
So what are the reasons for liver rejection? Like you said, basically one initially does a simple blood test for matching. That is
Yes.
a live. So what are the reasons that a liver gets,
I mean,
rejected?
because it's a foreign body, it's not your own, and your body recognizes your own and what is foreign. So your immune system starts acting against it, and these medications prevent your immune system, suppress your own immune system to prevent this from happening. So you have what's called acute rejection, which occurs in the first months. I mean, I'm sure Dr. Sandeep will be able to tell us more about this, but it happens in the first months or the first year after a transplant. And those kind of episodes can be easily, almost always, can be easily treated. But sometimes some patients either because their immunosuppression hasn't been adequate, or for a variety of reasons, they may develop what's called chronic rejection over many years, usually. And despite having taken their medication and all that, again, a very small group. And that's the group which may require transplant. Acute rejection requiring a retransplant is almost not, I mean, it just about doesn't happen because you're easily treated. Sandeep, would you like to add something?
Yeah, I think most of the points are covered. So I think just one important point to mention is that liver is a very, very tolerogenic organ. Now, what do I mean by that? It tolerates a lot. It is not like a kidney transplant. So after a kidney transplant, you require a very high level of immunosuppression. So you're worried about that your immunity is going to go down, you can catch infections, but liver, we are in a treat because we have to give a very low dose of immunosuppression and the liver does not reject. So first, acute rejections happen most of the times easily, I would say most of the times, in the sense 99% of the times, very easily treated. Sometimes it requires some admission. So virtually for acute rejection, we have never done a retransplant, never has been, I mean, it's not needed. But yes, sometimes what happens is the body identifies that this liver is not mine. And over a few years, there can be something called as a chronic rejection. Very, very minority of patients in that subgroup, yes. And that too, they linger on for more than 5 to 8 years. I have a lot of patients of chronic rejection who are doing very, very well, but maybe they know that after 5 years or 8 years, they might require a retransplant and they're okay with it. So it gives a lot of time. So for liver transplant, rejection is not a big concern at all.
So,
another reason,
please, doctor, please.
Another reason for a long-term liver transplant is the same disease coming on. For example, like an autoimmune liver disease may again affect the liver, and at maybe 10 years from then, you may require another transplant. But unfortunately, if they, as Sanjay said, don't have proper diet, and then they have a fatty liver, they, in addition to the cardiac and other problems, they may have a liver disease again and succumb. So these are some of the other things in the longer term.
Dr. Sandeep, I think you also mentioned in your presentation about what people should be careful of and how much, alcohol they can consume and all that. So post-operative, I mean, after the transplant surgery is done, what would be your advice, say, vis-a-vis diet specifically, vis-a-vis alcohol consumption specifically, or the people who smoke, for smokers, or even your exercise schedule? How does it change?
See, I think the guidelines are pretty much the same like what we need to follow, okay, without transplant, a healthy lifestyle. So only in the first 3 months do we tell them that don't take raw foods, uncooked foods. And, after 3 months, usually we reduce the level of immunosuppression by a lot. And after that, it is okay to take, your uncooked fruits and all those things after proper cleaning of them. And when it comes to other lifestyle advice, we always tell them 30 to 40 minutes of regular walking has to be done for life. Initially, after 1 year of transplant, they usually put on a lot of weight. I showed you a photo of a very muscle wasting, a person who becomes very malnourished. So obviously they put on a lot of weight, but sometimes people overshoot their targets. They become obese after 1 year. So that also can cause, as Dr. Ashok was pointing out, as fatty liver, and again affecting the new liver. So again, we have to tell them that, you have to restrict your calories, ensure that you're doing regular lifestyle, but that remains same for even us. It's a very same. Tobacco is bad, nicotine is bad for the liver, so that remains same. Now, alcohol is it's a very tricky sort of an area. Now, what happens is that it's not that, post-transplant, you can't take occasional 1 or 2 pegs, probably once a week or twice a week. But in India, the problem is that people don't remain there. You can't contain yourself. It starts with 1 time a week and slowly goes to 3 times a week and slowly becomes daily affair. And that's the problem that, we doctors don't actually advocate that. But if taken less than, 10 grams per day, just probably a small amount of wine, it actually doesn't hamper your new liver as well. But the message which I want to pass across is that this level of, curtailment to remain to that strict cutoff is seen in very less number of patients. So for all practical purposes, we say that no going back to alcohol, no going back to smoking, a routine, regular, healthy diet, and a 45 minutes of brisk walking daily.
Right. Dr. Chako, Mr. Prakash Somasundaram says that I am an RA patient and am on steroids 4 mg to 6 mg once daily for more than 4 years. Will it have a toll on my liver?
No, not steroids are not going to have a toll on the liver. But if they are taking a drug called methotrexate, then that has got a certain limit. If you take more than 5 grams, it can lead to cirrhosis of the liver. So if one is taking methotrexate, one has to be careful on the total dose taken and have regular liver function tests and checks by the doctor. But taking steroids alone, it will not cause permanent liver damage.
Dr. Gobel, there is a little technical question if you would like to take it. It says origination of liver progenitor cells, whether they originate.
Yeah, I haven't a clue. I mean, this is very much Dr. Sandeep's.
I see. Okay.
So I actually replied. It's a very interesting question. See, I think that there's a little confusion in that question. So LPC is what we call as liver progenitor cells. It's a very basic hepatology question. It's in the fetal liver coming from something called as an endoderm. And the most important point of an LPC is that it can turn into both hepatocytes or cholangiocytes. So it doesn't originate from them, but LPCs actually go on to develop either a hepatocyte or a cholangiocyte. And that's what I have actually replied to the audience asking that question.
Mm-hmm. I wanted to ask you, going back to the cost factor, like why haven't the gastroenterologists or hepatologists got together and fought for medical insurance cover for patients, given the cost involved?
So see, right now, I mean, the insurance companies are taking up and they are sponsoring our patients undergoing a liver transplant. It might not be a complete amount. So usually what happens is if it's a transplant cost is somewhere around 22 to 25 lakh rupees, they get probably around 10 to 12 lakh rupees from the insurance. So it depends on a lot of other things like what their cover is, but they do get. So now most of the insurances are actually having that clause that they are covering a future need for an organ transplant. But at the time of they taking the insurance, they should not be suffering from that disorder. So it is much before that. Probably, if I have hepatitis B right now, my sum might be a little higher. The insurance amount which I have to pay is a little higher. But if I land up with the liver cirrhosis later, they will sponsor it. So it is now most of the insurance agents are actually taking up this thing and giving a part of the amount for the transplant.
So when you yeah, sorry, please.
No, just to say that if you're alcoholic and it's alcoholic liver disease, you're not going to.
So alcohol is out for anything. Yeah,
you're out. But if it's any of the other reasons, you do get.
You do.
Yeah. Since you've done so many transplant surgeries, like for how many years the follow-up continues? Like how seriously the patients keep coming back to you, or whatever medicines you recommend or the tests they're supposed to do. So like from your hospital, and also you must be doing a follow-up of all the surgical cases that you've undertaken. So how long does it go on usually? Because the post-operative medical expenses are also not less.
Yeah, so I think expenses, I think Dr. Gobel aptly covered that initial 3 months, usually around 25 to 30,000 per month. And after that drastically starts to come down. Usually 4,000, 3,500 is after 1 year per month. What happens is, so post-operative, I handle these patients. So what happens is in the first 2 weeks of transplant, after the discharge, I call them twice a week. And these days, especially after the COVID, we have seen the COVID pandemic. Now those things have become online. So probably I just call them once a week. I send in the technicians from the hospital to draw the blood, and they get the blood test done and send me the reports on an online consult. But usual follow-up is 2 times a week for the first 2 weeks. Followed by that, it becomes 1 time a week, and then once in 15 days and once a month. Usually after the first 6 months, you have to do the blood test once in 2 months. And after first year, it's only once in 3 months. So progressively after the first year of transplant, it is just once in 3 months. And in very few patients, it's even once in 6 months that you have to actually do a blood test and remember your transplant team. Coming to the second part of question, how often you fall sick? It's not at all frequently. 3 months they stay in the place wherein the transplant was done, so that they can actually come back to the transplant center for any medical issues. But after 3 months, they actually go back to their hometown. So wherever the patient is coming from, they go back there. Usually what I do is I identify one very good physician in their local area, and that physician is in contact with me, so that if it's a very minor issue like COVID or some cold cough, some diarrhea, I can handle it over the phone. But if it is anything more severe connected to the liver transplant per se, then the physician would actually call me up and send the patient so that we can handle it over here. That happens very, very rarely.
Okay. So I've been given an indication that the time is up. So we need to wrap up. And I must thank all the doctors for this very informative and useful session on liver transplant brought to you by the Hindu Wellness Series and the Naruvi Hospitals. Thank you, participants, for helping with your questions. And I'm sure whoever has tuned in for the session also has taken a lot of takeaways from this discussion. Due to time limitation, we have also not been able to prolong the discussion or take more questions. But if the questions come by later, directed specifically to any doctor, we'll email them to you. So thank you once again, doctors, for sparing your valuable time on a Sunday afternoon. Thank you so much.
Thank you.
Thank you. Thank you very much.